of cholesterol. For cholesterol gallstones to form, bile must be supersaturated with cholesterol. Normally, water-insoluble cholesterol is made water-soluble by combining with bile acids and lecithin to form mixed micelles. Actually, the water-soluble bile acid, orthodeoxycholic acid, is very important for keeping cholesterol in solution in the gallbladder. Supersaturation of bile with cholesterol most commonly results from excessive cholesterol secretion, but may result from a decrease in bile salt secretion or in lecithin secretion. Black pigment stones are small, hard gallstones compared with calcium, composed of calcium bilirubinate and inorganic calcium salts. Factors that accelerate their development include alcoholic liver disease, chronic hemolysis, and older age. Brown pigment stones are soft and greasy, consisting of bilirubinate and fatty acids. They form during infection, inflammation, and parasitic infestation, and usually is formed above biliary strictures. As I mentioned, gallbladder stones grow at 1 to 2 millimeter per year. Signs and symptoms of gallstone disease: about 80% of people with gallstones are asymptomatic. The remainder have symptoms ranging from biliary type pain to cholecystitis to life-threatening cholangitis. Biliary colic is the most common symptom. Actually, you will know in surgery that uh, gallstones must be excised, and it's a big debate. Should we remove all gallbladders containing stones? Usually, we recommend observation in asymptomatic cases of gallstones, except in certain situations. If the patient is diabetic, we recommend removal of the gallbladder. If the patient having huge or large gallstone, we recommend removal of this stone because this large stone or huge stone in the gallbladder will stimulate or will irritate the gallbladder epithelium, producing cholecystitis, and it may be a factor for metaplasia, dysplasia, and gallbladder cancer. That's why it's recommended to be removed. Gallstone migration into cystic duct, which even if transient, causes biliary colic or biliary pain. Usually we describe biliary pain characteristically as being in the right upper quadrant, but may be actually occurring elsewhere in the upper abdomen. It is considered as an acute abdomen. We may have upper abdominal pain in the right hypochondrium, maybe in the epigastrium, maybe radiating to the right shoulder, maybe radiating to retrosternum, maybe in the left hypochondrium. All these are considered biliary pain related to the gallstone disease. So it's an upper abdominal pain. We should realize that it's in the differential diagnosis of acute abdomen with upper abdominal pain. Usually, pain is often poorly localized, particularly in diabetics and the elderly, due to the association with neuropathy. The pain may radiate into back or down the arm. Episodes begin suddenly, become intense within 15 minutes to 1 hour, remain at steady state or steady intensity for up to 12 hours, and then gradually disappear over 30 to 90 minutes, leaving a dull ache. The pain is usually severe enough to send patient to the emergency department for relief. Nausea and sometimes vomiting are commonly, but fever and chills don't occur unless cholecystitis has developed. And usually, nausea and vomiting is associated like with any other visceral pain. It's considered as autonomic nervous system manifestation. Mild right upper quadrant or epigastric tenderness may be present. Peritoneal findings are absent, and this differentiated from peritonitis, for example. Between episodes, patients feels well because in 95% of the cases you will find the stone is impacted at the gallbladder neck, and it will be a cause of acute cholecystitis. The clinical findings include shallow respiration like any painful condition in the abdomen, fever, jaundice, and you will find Murphy sign is positive. And we mean by Murphy sign tenderness at the gallbladder point. That's the intersection of the midclavicular line with costal margin. Tender mass at the gallbladder region indicates mucocele of the gallbladder or myocele of the gallbladder. And at times, if you have gallbladder cancer, you will feel a hard mass at the gallbladder point. White blood cell is high, and this leukocytosis is very important because if it is polymorph leukocytosis, it indicates bacterial infection. But if you have excessive eosinophils in the peripheral blood picture, this indicates parasitic infestation. And in our country, we say that it's an important statement. If you have severe eosinophilia, it's related to fasciolysis till proved otherwise. The biliary type pain, although biliary type pain can follow a heavy meal, fatty food is usually a precipitating factor. Non-specific GI symptoms such as gas, bloating, and nausea have been commonly associated with gallbladder disease. And usually we say that this triage of symptoms, that's dyspepsia, excess gas, and bloating with nausea, usually we call it fatty dyspepsia, as it occurs more commonly with fatty food. Little correlation exists between the severity and the frequency of biliary pain and pathological changes in the gallbladder. Biliary pain can occur in the absence of cholestasis. Should pain last more than 12 hours, particularly if accompanied by vomiting, fever, acute cholestasis or pancreatitis is likely. And in this condition, if you have epigastric pain in a patient with gallstone disease, you have to suspect two conditions which are very important: migration of stones into the common bile duct, or you may have associated biliary pancreatitis. That is pancreatitis due to impaction of stone at the papilla of water. Biliary pancreatitis means that it's pancreatitis with jaundice, and usually it's due to impaction of stone at the papilla of water, which produce obstruction of the pancreatic duct and the common bile duct. And this is very important diagnosis. The natural history of gallstones, about 70% remain asymptomatic, and about 2 to 3 per year, 2 to 3% per year will have an attack of biliary colic, and 0.2% per year will have acute cholestasis. Once they have acute cholestasis, it will pass into chronic cholestasis, and it may have complications. And usually we say that asymptomatic gallstones is a benign gallstones, but symptomatic gallstones usually will have complications. As chronic cholestatis, they have migration of the stone in the common bile duct. It may be associated with pancreatitis or cholangitis. And here, when we say cholangitis, you should remember the Charcot's triad, which includes jaundice, cholangitis or jaundice, fever, and chills or chilling. This is very important. You find jaundice, fever, and chills. Gallbladder carcinoma, as we mentioned, its prevalence is 0.08% per year of symptomatic gallstones over 50 years age. This slide shows you how much numerous are gallstones in the gallbladder and even migrating into cystic duct. And this is very important because it indicates that there are many nucleated factors in this gallbladder. Prognosis: those with asymptomatic gallstones become symptomatic at a rate of about 2% per year. The symptom that develops most commonly is biliary pain rather than major biliary complication. Once biliary symptoms begin, they are likely to recur. And pain returns in 20 to 40% of patients every year, while 1 to 2% of patients will develop complications such as cholestasis, cholelocolitis, cholangitis, and gallstone pancreatitis. And this is very important because symptomatic gallstones should be removed. We should remove the gallbladder. You may read about acute and chronic cholestasis. In 96%, cystic duct is obstructed in acute cholestasis. Clinical features: sufferers are often obese, fertile, female over 40. Pain occur late at night in right hypochondrium, epigastric, and refer to right shoulder. Digestive symptoms: flatulence, nausea, vomiting. Fever occur in association with bacterial infection. This term, acalculous cholecystitis, sometimes is important to remember what's meant and how it's common. 5 to 10% of acute cholecystitis in adults, usually it is acalculous. 30% in children. Factors associated with critical conditions include major surgery, multiple injuries, and in patients with severe sepsis or on mechanical ventilation. Bacterial infection, especially with typhoid bacilli, always it's mentioned that gallbladder is a hidden site for typhoid bacilli. But with the recent antibiotics, this is very rare because it was very important to remember this, as presence of typhoid bacilli in the gallbladder was considered to be precancerous condition. Actinomycosis, very rarely to have a case of actinomycosis, but what's more common is parasitic cholecystitis. A rare type of cholecystitis you see in this picture, you find what's mentioned as aerobelia or air in the gallbladder. It's called emphysematous cholecystitis. This is very important because this type of cholecystitis is seen in compromised patients who are infected with gas-forming organisms, especially Clostridia urchii. The treatment, usually treatment or the gold standard for the treatment of gallstone disease is removal of the gallbladder. Laparoscopic cholecystectomy for symptomatic gallstones actually is indicated. Expectant for asymptomatic stone, sometimes stone dissolution. At a time, there was a trend to dissolve cholesterol stones, and it's a long story. You have at first to confirm that the stones uh, are all cholesterol stones and not calcified stones. And to do this, we have to do CT scan examination. We have to make aspiration of the duodenal bile to see cholesterol crystals in the duodenal bile, and then we introduce a pigtail caster into the gallbladder under screen and start to inject a material that's called methyl tertibutyl ether to dissolve the stones, and we confirm this by injection